Protocol 42 is our overdose, poisoning, and toxic ingestion adult protocol. And this deals with overdoses of beta blockers, calcium channel blockers, and tricyclic antidepressants, as well as organophosphate poisoning, cyanide, and carbon monoxide. And in the instance of cyanide and carbon monoxide, it asks us to exit to the carbon monoxide smoke inhalation protocol, Protocol 23. Okay, Protocol 42 also covers narcotic overdose. At the top right-hand corner, there's a note on administration of naloxone. You can administer up to 2 milligrams, IV, IO, IN, or IM. However, we give naloxone to affect adequate oxygenation and ventilations. We do not give it to restore consciousness to our patients. For our beta blocker or calcium channel blocker overdoses at the IMP level, we will be administering glucagon, 3 milligrams IV or IO. We want to consider cardiac external pacing for severe cases of bradycardia. Also, calcium chloride at 1 to 2 grams IV IO over 3 minutes. And dopamine as our pressor, 2 to 20 micrograms per kilogram per minute. For our tricyclic antidepressant overdoses at the IMP level, if the QRS is greater than 0.12 seconds, so we have a wide QRS, we're going to administer the sodium bicarbonate, 50 milliequivalents IV IO, and you can repeat in 5 minutes if the QRS remains wide. Now for our organophosphate poisonings, we have the nerve agent antidote kit, the Duodote, or the 2 medications that are in the Duodote, depending on how we're carrying it, is atropine, 2 milligrams, IV, IO, IM, every 5 minutes if symptoms persist, and those symptoms are the symptoms of sludgem, salivation, lacrimation, urination, defecation, GI upset, emesis, and muscle twitching. And we will also administer prolixidine, or 2-PAM, at 1,800 milligrams IV, IO, or IM. And as I said before, if your patient is a cyanide CO or smoke inhalation exposure patient and we consider cyanide poisoning, we're going to exit to Protocol 23. Okay, Protocol 43 is our overdose, poisoning, toxic ingestion pediatric patient. Again, it's broken down between beta blocker overdose, calcium channel blocker overdose, tricyclic antidepressant overdose, organophosphate poisoning, and cyanide carbon monoxide asks you to exit to Protocol 23. Top right-hand corner here, we have our Narcan doses. We're going to cover those in the next slide. Okay, so for our advanced providers, in the instance of narcotic overdose, they can administer naloxone to the pediatric patient, and the dose is 0.1 milligrams per kilogram, and they can only administer it IN or IM. And remember, Narcan is titrated to the effect of adequate oxygenation and ventilation, not given to restore consciousness. Now, for the INP level provider, they can administer naloxone IV and IO as well. Same dose, 0.1 milligrams per kilogram. Okay, so for our beta blocker or calcium channel blocker overdoses, the INP level providers will be administering glucagon at 0.5 milligrams IV IO, max of 2 milligrams. We want to consider cardiac pacing for the severe cases of bradycardia. And calcium chloride, 60 milligrams per kilogram, IV IO over 3 minutes. Dopamine is your pressor of choice at 2 to 20 micrograms per kilogram a minute. For our tricyclic antidepressant overdose patients that are pediatric, our IMP level providers, you're going to be looking at your ECG. Is there a wide QRS greater than 0.10 seconds? You're going to administer sodium bicarbonate at 1 milliequivalent per kilogram IV IO, and you can repeat in 5 minutes if those QRSs remain wide. For organophosphate poisoning or nerve agents, our IMP level providers will be administering atropine, 0.05 to 0.1 milligrams per kilogram IV IO or IM. This is every 5 minutes as long as the symptoms of sludgem persist. Also, you will be administering prolixidine or 2-PAM at 25 to 50 milligrams per kilogram IV, IO, or IM. And for cyanide CO and smoke inhalation, again, you will exit to Protocol 23. Protocol 44 is our pulmonary edema CHF protocol. Okay, so the pulmonary edema CHF protocol is broken down between mild, moderate, and cardiogenic shock. And for the mild pulmonary edema patient, The advanced through paramedic level provider is able to administer nitroglycerin at 0.4 milligrams sublingual, and they can repeat this every 5 minutes 3 times. They're also going to administer nitro paste, 1 inch, to maintain a systolic blood pressure greater than 90 millimeters of mercury. Now, if the patient is a moderate pulmonary edema patient, all provider levels will initiate CPAP procedures and also administer nitro sublingual and paste if they have not already done so. The I and P level providers in the moderate pulmonary edema patient will administer diuretics, furosemide, at 0.5 milligrams per kilogram IV if the patient is not already prescribed furosemide. And if the patient is prescribed furosemide, they will administer 1 milligram per kilogram IV. Now, the cardiogenic shock patient, the I and P level provider will administer dopamine at 5 to 20 micrograms per kilogram per minute IV-IO, and they're going to titrate to maintain that systolic blood pressure greater than 90 millimeters of mercury. Okay, so just a note on this protocol, if BLS has already treated the patient, be aware they may have began nitrotherapy already. Same is true for the cardiac chest pain protocol. And also CPAP, we want to begin at 0 centimeters of H2O PEEP, or positive end expiratory pressure, and slowly titrate to achieve a positive pressure of 5 to 10 centimeters of H2O, and we're going to cover this extensively in the skills training. The IMP level provider do not administer furosemide during pregnancy, or if hyperkalemia is suspected, and if cardiogenic shock is suspected, administer dopamine, 5 to 20 micrograms per kilogram per minute. Protocol 45 is our respiratory distress adult protocol. Now, this is broken down between a wheezing and a stridor patient. So for our wheezing patients, all provider levels will be administering albuterol, 2.5 milligrams in 3 mLs normal saline times 3 as needed, as well as CPAP. Our IMP level providers will be administering methylprednisolone or solumedrol at 125 milligrams IV-IO or deep-IM, and mag sulfate at 2 grams IV-IO over 5 minutes. So our patients that present with stridor, all provider levels will have the ability to administer CPAP if indicated. Our IMP level providers will nebulize epinephrine, 2 milligrams of 1 to 1,000 in 2 mLs of normal saline, as well as administers methylprednisolone or solumedrol at 125 milligrams IV-IO or deep-IM.